Well, thank you, Mr. Chairman, and thank you for allowing me to participate here. Mr. Chacha, you just heard what Mr. Caldwell had to say, and I read your papers all the time, and I find them to be somewhat balanced. I mean, you bring out some good points often about what PBMs can do. Do you have any response to what he just said as far as its connectivity especially? I find that very disturbing, but I don't want to preface this. I just want to give you a chance to respond to that.
So, to the chair, to Congressman Carter, the functionality that PBMs provide in the drug supply chain, I believe, is actually very crucial. If left to their own devices, let's just look at the supply chain very simply. Drug makers would ostensibly like to charge as much as the market would bear. They sell to wholesalers who would love to charge as much as the market would bear. And they sell to pharmacies who would also like to charge probably as much as the market would bear. For those that pay the bill, all right, employers, government programs, et cetera, they need a necessary balancing friction to say, well, maybe not as much as everybody else who I just mentioned would like to charge. And so PBMs were brought in to act as a necessary facilitator of the transaction and as a necessary balancing act to make sure that drug purchases were efficient and also make sure that access was available for beneficiaries on behalf of plan sponsors. What happened over time is that became distorted. Rather than just working to make things more efficient, they actually created, I think, they added more gasoline to the fire of rising prescription drug costs. If you and I were to go into a grocery store and buy a gallon of milk and see that it was $20, we would know we're getting ripped off, right? We don't know that with prescription drugs. And so anytime that somebody makes money off of the list price of medication, all right, there's a big delta between the list price and the real price of that drug. And so anybody who can make money off the delta becomes compromised. And when PBM stopped essentially just acting to facilitate the claims transaction and instead started making money off the drug makers through the rebates, off the pharmacies through the clawbacks and the spread pricing, their incentives became incredibly distorted, and you essentially had the saint become sinner. And unsurprisingly, the entire drug channel now, including PBMs and health insurers, as was said earlier, benefit when list prices become further and further disconnected from
Absolutely. And to your point, I'm old enough to remember when PBMs were nothing more than processors. They were processing claims, and they did serve a good purpose for that. But they have become much more than that. We had a hearing in Energy and Commerce back in May, and we had Dr. Gupta had spoke to us as a witness, and he testified that only 53% of what patients spend on prescription drugs makes it back to the manufacturer. 47% goes to the middleman. Can you justify the value that PBMs bring to the healthcare system in order to get 47% of the cost of a drug?
Mr. Chairman, Congressman, based on the services that we see traditionally provided, the answer would be no, right?
Okay.
You know, what we typically see is that a PBM service, and this is generalizing and somewhat unfair, a PBM, anywhere from $1, $2, if you're really going high, $3 for the administrative functions per claim to fulfill their role. And the Ohio Medicaid audit that showed PBMs taking about $6 per claim, all right, that was about 3 to 6 times the going rate according to their own audits. So the question is not whether or not PBMs deserve to be compensated. The question is, how are they compensated, and do they have the ability to print their own money when facilitating the transaction? That becomes the problem.
Okay. All right. Let me move on. Thank you for that. Mr. Ocon, I want to ask you, DIR fees, we've been talking about that, and they have gone up from $229 million in 2013 to an estimated $9.1 billion in 2019. Unbelievable. As I believe Ms. Jones pointed out, 91,500% increase. Now, understand what a clawback is. As a pharmacy, you get paid, and then months, sometimes years later, the PBM comes back and claws back that payment. How do you operate a business like that, or do you?
You can't, and I'll put this in simple terms. And first of all, I'll give you an update, Congressman. In 2020, it was $11.2 billion. So that's an updated figure. Bottom line is, imagine going to a supermarket, buying 25 items for $4, paying your $100, walking away, and imagine 6 months later the supermarket sends you a $10 bill. For what? You don't really know. You're going to say, I'm never going to that supermarket again. That's it. You're not going to pay it. That's what a DIR fee is. The problem is that a pharmacy, whether it's an independent pharmacy or associated with an oncology practice, cannot say no because the clout of these PBMs. So they can't say no, and not only that, they don't pay the money is taken out of their reimbursement. So this is a game that's rigged just like three-card Monte is rigged on a street corner. And it's why you see the amount of money that now PBMs make from DIR fees. And I think it's because their rebates have become under attack. So they've gone downstream to independent pharmacies, to practices that have pharmacies, and that's what they've done. It's crime.
And ultimately, who suffers?
Ultimately, the patient.
Thank
it's
you.
the patient.
Thank you, and I'll yield back, Mr. Chairman.